just a second to Phil Feisal. He's the president of Spartanburg Medical Center, Church Street, and Mary Black. And just let him expand just a little bit on what we've done in terms of increasing hospital capacity.
Thank you, Dr. Longo. This is Phil Feisal, the president of Spartanburg Medical Center, and I've been tasked with some of the responsibility of preparing us from a capacity perspective system-wide. And just to note the impact that some of the decisions that we've made over the last 3 weeks have resulted for us. The postponement of elective surgeries, in particular, just over 3 weeks ago, we were, as a system, about 85% occupied as a system, which includes all 5 acute care facilities, the 2 here in Spartanburg proper, at Pelham, at Union, and at Cherokee. Today we are at about 56% occupied. We actually sit with 234 more empty beds today than we did just 3 weeks and 3 days ago. So to that end, we are preparing ourselves for the surge that would be that scenario that we all hope doesn't happen, but we need to be prepared for. Along those lines, we continue to work with our staff as we have expectations of redeploying some of those individuals to different units as we prepare for what might be to come going forward. So we have made a lot of strides in that regard. I'll turn it back over to Dr. Montgomery to talk a little more specifically about our preparation related to ventilators and those other services.
Thank you. So one of the things that you may have heard about is this flattening of the curve and preparing for peaks. So the things that the community is doing right now in regards to staying at home, closing businesses, all of that is getting us ready for this possible surge. We believe, based on projections from a number of different sites, including DHEC, that the surge for the upstate will probably occur in the last week of April, perhaps the first week of May. These are projections, so certainly they're subject to change and could, certainly as you get closer to those actual dates, they'll become more accurate. But that seems to be the best estimate right now. So late April, early May is when we think we're going to see a large surge in patients who will require hospitalization and critical care. So the measures that we're taking now are in preparation for that, making sure that we have enough critical care beds, that we have an appropriate plan to expand coverage as needed, that we have the right equipment, and that the key equipment for this particular disease is a ventilator. And we are fortunate that we've planned ahead. We believe we've got adequate ventilators. And in fact, like a lot of healthcare systems, we plan for the exigencies of what happens if we have double or triple or quadruple the number of patients that we expect in a surge. And even if that happens, we still think that we have enough equipment to manage that. It would be with some innovation and with some hard work. But even if that would occur, we think we can handle our surge population. We don't think that's going to happen. I want to make that clear. But even in the worst case of that, we think we're well prepared for it. Testing is another issue that comes up all the time. And I think it's fair to say that South Carolina, like a lot of other states, was woefully short in terms of its testing capabilities. And I certainly understand why. It was important that testing capability be sent to the hotspots, Seattle, California, now New York. And as testing capabilities have ramped up, that's now becoming more available to states like South Carolina and the upstate. For those of you who are not aware, most of the healthcare systems have a combination of testing through DHEC and testing through other vendors. The other vendors, commercial vendors, have also been overloaded with work and have not been able to keep up. Again, completely expected when you have surges like this. Unfortunately, what that means is that the delay to results has been anywhere from about 4 days up to 8 or 9 days. And if you can imagine two scenarios, one, you're not terribly sick, you got a test, you're waiting at home for a result, you're not quite sure what the result's going to be, so you're on home isolation, you're staying away from your family, you're making sure you're 6 feet away from anyone that you possibly come into contact with, you're wearing a mask, you're practicing great hand hygiene, all those sorts of things, but you're worried. And it takes a week to get a result back, and hopefully you're getting better. Turn that around and think of the patient who's in the hospital or presented to the emergency department. If someone like me is seeing someone like you in the emergency department and I can do a rapid test similar to, say, a flu test or common blood test that we do on a regular basis and get an answer within minutes or even within hours, that can definitively change our management of what we're going to do. And instead, what many hospitals have been caught up with is admitting a patient, observing that patient, managing the symptoms, doing the best we can, and waiting for several days to get answers. And that makes the management extraordinarily difficult. It makes the resource utilization much higher than it necessarily needs to be, and ultimately adds to the burden of trying to take care of everyone. I do know that there are rapid tests coming, but also those companies are trying to ramp up, and we don't expect anything in the near future. So we're not sure when that will be available in a meaningful way in the upstate, but right now, all we can do is hope for it. The testing criteria has not changed a whole lot. We follow the CDC guidelines and DHEC guidelines closely. About the only thing that has changed significantly is that where travel and contact used to be a significant portion of how we determine whether or not we're going to do tests, at this point with community spread and travel not being terribly important, it really comes down to symptoms and whether or not the person meets the symptomatic criteria for testing. And that's essentially fever, cough, shortness of breath. There are a couple of other things, but those are the main symptoms that we're looking for. If those patients meet those symptoms and are looking for testing, they can go through a variety of ways to seek care. They can go to our local practices, the MGC offices. They can go to the intermediate care centers, or easier for most people, they can use an e-visit through our MyChart system, and we also have virtual care options through NUSC. So there are a variety of ways to get screened. And then some good news this week, some of you are already aware, if you meet that screening criteria and testing is indicated, then we're directing you to our drive-through testing currently at USC Upstate, and also just started today in Union and in Cherokee counties. I would say on Monday we had 40 patients tested. We had 80 tested yesterday, and it looks like we'll be close to 100 today by the time the day is all done. So that will certainly increase the availability and give us better visibility in terms of what's actually happening out in the community. Certainly for patients who are very ill, those patients are still referred to the local emergency department. We're more than happy and ready and willing to take care of them. I want to commend the upstate hospitals. We have been